Thank you, Dr. Unni, for yet again giving me the opportunity to be a part of this discussion once again. So pretty much, there's a slight touch from all the speakers towards the choroid that we heard in the morning. These are my disclosures. So we are all aware that how important the choroid is because the kind of nutrition is provided to the outer layers. And till now, as we were discussing about the OCT, till now it's still pretty much ICG is the gold standard in many cases because that is the one which gives you the perfusion analysis. And OCT is still evolving. And although there are some practical problems with ICG because of its availability, which is not there everywhere, and at the end of the day, it is an invasive investigation. So since the OCT started, and then when the first time Dr. Spade, he came with the concept that you can image choroid easily in a normal spectral domain OCT with a slight shifting the zero delay line, which is nothing but just you shift your lens towards the patient and then take the inverted image. But now with the help of EDI softwares, you can image in all these spectral domain OCT machines. The problem with this was that you are not actually seeing much details on the vitreous side. You are seeing a lot of details here. So over the time, as previous speakers mentioned, that with the better wavelength, you can image both the sides much clearer and the wider. So the million-dollar question is whether imaging of the choroid is really useful. The reason I am asking this question is just look at this normal choroidal thickness. It starts from 191 up to 354. Look at the variability. The variability is approximately 160 micron. And if you look at in the central macula also, there are different pockets. Each has a different thickness. And even that the same with the optic disc. Choroidal thickness varies with the age. With each decade, the choroidal thickness thins out. With each diopter, it thins out. Even it changes within the day. On top of that, when you look at this choroidal thickness, the inner boundary is easy. You have a clear interface. But outer boundary is a problem because that's where sometimes you cannot really make out that from where it should be measured. So having such a dynamic and such a variable structure, do you really think that, it helps you? The answer, surprisingly, is yes. Because you are not going to, take decisions just on the basis of few microns. You are going to take decisions on the basis of the structure and the overall thickness of the choroid. So I'm going to talk about, in next few slides, the machine that probably in the hall everybody would have, a spectral domain OCT, and how it helps you in taking a lot of clinical decisions in terms of the diagnosis and the treatment. For example, if you wouldn't have the spectral domain OCT, there was a time that these kind of images, you would have just mentioned or labeled that RP changes, or probably a geographic atrophy. But if you look at the image, just a normal spectral domain OCT image, choroid is absolutely thinned out. But RP is good. Photoreceptor layer is good. So that's how you differentiate a geographic atrophy, where you have even the RP is also completely thinned out. So you have a prognostic point to make here that this is a case where I can give a better prognosis compared to the geographic atrophy. So this was again a modality again coined by Spade as an age-related choroidal atrophy. Another case, you must be seeing a lot of myopes. A lot of myopes, you see this kind of elevation, which we call as a dome-shaped macula. Dome-shaped macula, again, the reason is just within that staphylomatous area, you have a slight convex area. Below that, you have a choroidal thickness. And sometimes you see this kind of NSD, not essential to treat, because there is no pathology here. Probably that's where little bit OCTA is helping us in case to just identify subtle NVs, CNV if you have. That is the only case when you treat these cases. So again, important in decision making with just the spectral domain OCT. Now this is, everybody is seeing these cases in your day-to-day clinical practice, how it helps and how it has immensely changed our understanding that how you should be treating these cases. For example, on the left side, you look at this case. Case treated. You had a leakage in FFA, you treated it, and then everything is resolved anteriorly. But look at the choroidal thickness. Choroidal thickness remains the same. However, on the right side, if you see, again, you treated this patient in a different way with the PDT. Choroidal thickness changed. So that's where choroidal imaging has helped us to understand that probably PDT is a much better choice in treating these cases. Again, this is the disease which is quite close to my heart, where again, choroidal imaging helps you. Just a spectral domain OCT helps you a lot. Why? For example, if you just look at this case present in the beginning, you can't even make out the posterior boundary because it's too thick. So you cannot, so choroidal is too thick, and you can see a lot of HRS, which is a predictor, which is a sign of hyperreflectivity, a sign of inflammation in both right and the left eye. Once you give 3 doses of the pulse therapy, you can measure the choroid now. But on the other side also you can measure the choroid now, posterior boundary comes in. But now look at the 3 weeks after the steroid therapy. Left eye already has a quite anterior recurrence. But I'm not, this is not the one which we should learn from, but basically just look at the C, concentrate on this. Again, after seeing the good posterior boundary, you are not seeing the posterior boundary now. So this is the time when again choroidal imaging helps you, you step up your therapy, which before the anterior recurrence comes in. Because anterior recurrence is the one which is going to deteriorate the visual acuity over the time. So that's where the normal spectral domain choroidal imaging helps you. Now, these cases we all are seeing day in and day out. This is the case which came to me day before yesterday, just for an opinion before cataract surgery. Just look at the central fovea. This slide I have just put up, if some of you, if you have not really familiar in a normal spectral domain OCT pachychoroid, just to differentiate. Look at this normal picture of the right eye. Look at the choroidal vessels, absolutely fine, no problems. Left eye, very subtle, some RP changes if you see. We were labeling all these RP changes just like RP changes before. We didn't have the choroidal imaging. But if you see the choroid in a normal single line scan, these are big vessels lining here. And the entire choriocapillaries is completely compressed. So that's where you make a decision that I'm going to follow up these patients even more regularly compared to the other patients. Again, another patient, look at this, very subtle RP changes. And once you track this along with the line scan, just till here, everything is all right. Choriocapillaries are all right. But if you just come here, big choroidal vessels compressing the choriocapillaries completely. So as everybody, I think, has touched upon the importance of the pachychoroid, pachychoroid is the one, which is being helped by choroidal imaging immensely, and you do not need sophisticated instruments, even normal spectral domain OCT, you can very well do it. Now, AMD is not really, the tool that we are currently using in day-to-day, making some decisions in terms of the treatment. But for example, as I think Shroff also said, that there are some cases which OCT actually is a better tool if you really want to see, but there are some times when you have fundus photography appearance which confuses you. That, probably whether I am dealing with an AMD or I am dealing with some kind of vitelliform dystrophy. So in all the AMDs, you see predominantly thinning of the choroid, while in the dystrophy, you see the thickness of the choroid. But probably, in OCTA is a better tool right here. There are some other areas which we do not use them, choroidal imaging, as a clinical decision-making tool as of now, maybe in future. For example, in diabetic retinopathy, because we do not have the real evidences yet in terms of the choroidal imaging. Diabetic retinopathy, retinal dystrophy, choroidal vascularity index, choroidal volume, and choroidal vascular thickness analysis. So choroidal is a wonderful tool, even with the normal spectral domain OCT, I think, which everybody must be having if they have the retina practice. Thank you.
Can you just enlighten us something about the choroidal vascularity index that you've just mentioned, something just basic about that?
Yeah, so choroidal vascularity index basically means you go further back, and there are some methods, for example, like binarization method. You can have the volumetric analysis, and then you can have the smaller vessels and the larger vessel, the ratio of them. so that you can predict, okay, probably, the larger vessels and the lower other vessels are compressed. So probably means this is an analysis which you can do better with this, probably the swapped source machines. And as of now, practically I have never used them. So probably if somebody has used them, they can give a better insight on that.
Darius, anything?
It's more like the stroma versus the vascularity, the ratio which they're seeing, and I think Dr. Rupesh has done a lot of work on that. And I think the pattern is very, very fascinating. For example, we are seeing our own, I think in the beginning one of the speakers showed peripapillary pachychoroid. So then you get a totally different kind of, so when you trace the choroid near the optic disc, it's really thick, and then you go towards the macula, it becomes thin. And all other eyes, it's just the inverse. So I think there's a lot to be learned from this and from imaging it.
But as you said, there's been a shift towards the ratio between the vascularity to stroma to now choriocapillary density index, and a choriocapillary vascularity index is now becoming more and more relevant these days. The correlation of these two, regression and recurrence of CNVM, is being studied nowadays. Thank you. Do we have any questions? Where we've just finished way a bit early. We've got 10 minutes for any discussion or questions if you have any.
Are you doing stereo angiography with using the Heidelberg system? Because we had a discussion on this in DRF, because I think in Singapore the groups are using it a lot.
Yeah.
And
we're not doing it. We're not doing it. The obvious reason being the volume of patients you have and the amount of time it takes to take stereoscopic pairs. So I think that was a part of the Everest, diagnostic criteria, the stereoscopic images.
Not only anybody using choroidal volume? Anybody's measuring choroidal volumes as of now?
It's not standardized. We've tried a bit of image J modification. We've done a bit of study on the image J modification, getting the volumes, but it doesn't.
Did you correlate it with the real SF, subfoveal thickness? Does it really correlate?
We have a study on subfoveal thickness, but we haven't done anything on the choroidal volumes. We've tried measuring it, but it's still
doing, with the image J, variability is pretty high.
Yeah. Thank you.
I had a question for Dr. Darius. Any tips that you have to avoid artifacts while capturing an OCTA image? And especially in those cases who have a bilateral poor visual acuity, it's pretty difficult to get a good image because they can't focus for about a few seconds. So any tips in that?
I think that's one of the limitations of the technology probably, because we can't do anything about that. I think with faster scanning speed, that will be this thing. I think that's the only thing.
Yeah. There are some modifications that are now out. One is that reducing the raster to just the area of interest. And I think there is a proprietary scan from Spectralis that is coming. It was called Dense B scan. I think it is coming out under some other name now, where you can take a really small scan only at the pathology. And what that does is that it makes sure that you have a high resolution. It is done faster, very dense scans in a very small area.
Can you elaborate on how does PDT shrinks the choroid? You said PDT is a better modality of treatment for these conditions. Now I just want to start thinking about it, that how does PDT is going to go through all these RP layers and shrink the choroid vessels?
Yes, absolutely.
How does it do it? I mean, I haven't seen many references to this.
So as you said, the way the PDT works is on the wavelength and the kind of dye that you inject, and everything is absorbed by the choroidal vasculature. So basically the entire laser works on the area where the dye is being absorbed.
Okay.
So those are the dilated vessels, especially in the pachychoroid cases, where entire dye goes in and the laser works especially in that area. And once laser works in that area, then the shrinking comes in.
Okay. I mean, I just wanted references for this.
We may not be very sure how it works in the choroid.
But probably, you know,
It's really difficult to understand. Because
So the
if
principle.
it works, then probably PDT can be revived into a very big way. This.
No, but,
because pachychoroid, gradually we are seeing so many patients, we don't know what to do with them.
Yeah.
I mean,
So
even a RP,
a lot of
RP focal detachments, we see cases where with choroidal thickening, choroidal CVI, and if that works.
So probably, sir, because of that understanding, we are treating more and more CSR cases with the PDT.
Sure, that's true.
Thank you, Dr. Ashish.